So we have now come to our last, but certainly not least speaker of the meeting, Dr. Zuri Tutuncu, who is Assistant Clinical Professor at the Division of Rheumatology at UCSD. She is a graduate of the medical school at Istanbul, Turkey, and holds a degree in both rheumatology and physical therapy. So in her own training, she is interdisciplinary, just like this conference. She also trained at the most prestigious universities and rheumatological centers in Europe, including the Erasmus University in Rotterdam, the Ludwig Maximilian University in Munich, Germany, and the Royal National Hospital for Rheumatic Diseases in Bath, England. She did her fellowship training in rheumatology at the Division of Rheumatology at UCSD, and she is currently Assistant Director of the Center for Innovative Therapy at UCSD. I'd like to welcome you up to the podium, Dr. Tutuncu, to speak on pain syndromes in rheumatology. Thank you.
Thank you very much. So after a tiring 3 days, I'm the last speaker. I hope my talk will be interesting for you. In the next 1 hour, I will be mostly concentrating on the most common inflammatory arthritic condition, rheumatoid arthritis. And I will shortly review seronegative arthropathies, including psoriatic arthritis, and their novel management strategies. As you all know, rheumatoid arthritis is a chronic systemic inflammatory condition, and its prevalence ranges from 0.5 to 1%, affecting nearly 2.5 million Americans and 165 million people worldwide. And its prevalence may be different depending on the ethnic background, such as in American Indian tribes, it could be as high as 7%, and it could be very rare in some regions, such as Southern Africa. Of course, there is a female predominance, 3-to-1 ratio is estimated. Peak ages 35 to 45, but this disease presents in any age during lifespan. Recently, elderly patients have been estimated to have high prevalence of rheumatoid arthritis, which could be misleading in the diagnosis. It could be differential diagnosis could include crystal-induced arthritis, polymyalgia rheumatica, and we should be very alerted. Of course, the annual incidence is a lot higher in female population. So what is the gender influence? There has been questions about estrogen's influence, stimulatory influence on the immune system, but there are no final answers. There are some reports which suggest that oral contraceptives may protect women from having severe disease. And during pregnancy, 70 to 75% of patients achieve some degree of remission, especially in the first trimester. Again, an hormonal influence postulated, but not determined. Men and women have this disease, but there are differences in the presentation and the way they have it, such as Sika syndrome, dry eyes and dry mouth, is more common in females. Rheumatoid lung and rheumatoid nodules are more common in men. Mortality rates are higher in this population, very higher, 27% higher than the general population, and this is even significantly higher in women. Life expectancy in these patients are significantly diminished. It could be as much as 18 years compared to the age-matched and sex-matched controls without rheumatoid arthritis. Morbidity is increased as well. Myocardial infarction, stroke, and infection is have a lot higher incidence in the rheumatoid arthritis population. Increased lymphoma has been very well demonstrated, up to 25-fold higher risk, depending on the severity of the disease and the exposure of the immunosuppressive drugs, including methotrexate. Increased morbidity in women is also significantly higher than men. The etiology of rheumatoid arthritis is presently unknown. We know that it is multifactorial. Infectious agents such as rubella, Epstein-Barr virus, and other microorganisms have been blamed, but no conclusive evidence have been finalized. Genetic susceptibility. Predisposition to developing rheumatoid arthritis has been demonstrated in certain genetic populations. Especially, this is clearly defined in class 2 MHC, certain alleles, HLA-DR4, 14, and 1 has been blamed. In addition to genetic susceptibility and shared epitope theories, there are other entities that were looked at: enhanced T-cell responses, autoimmune mechanisms, intrinsic abnormalities, even in the synovial area. Looking at the racial differences and prevalence of rheumatoid arthritis, in addition to genetic effects, environmental factors also have been analyzed. Let's look at the pathogenesis of rheumatoid arthritis. There are many cells involved in this process. The key role is played by T cells, antigen-presenting cells, B cells playing a role as antigen-presenting cell, and also producing rheumatoid factors. Macrophages in interplay with other cells, releasing pro-inflammatory cytokines, which results in synovial inflammation, chondrocyte degradation, and bone resorption. Let's take a closer look at the joint. Here in this knee joint, you see shown in pink, the smooth synovial membrane. In early rheumatoid arthritis, the synovial membrane becomes hyperplastic and synovicytes are hypertrophic. And in addition, there are inflammatory mononuclear cells such as T cells and B cells. As the disease progresses, synovial villi become larger and they are called pannus, which has the capacity to invade the bone and cartilage. What are the diagnostic and prognostic tools in laboratory? It could be sometimes difficult to diagnose a rheumatoid arthritis patient, especially an early rheumatoid arthritis patient. As acute phase reactants, rheumatologists use C-reactive protein and sedimentation rate. CRP is a more direct measure of inflammation than sedimentation rate, and it is more sensitive to short-term changes. And also CRP levels have been shown to correlate with X-ray damage. Rheumatoid factor is an antibody that is produced towards the Fc portion of the IgG molecule. It could be IgM, IgG, IgA, but most commonly looked at one is IgM. There have been many other antibodies that have been shown in the rheumatoid sera. Among these, anti-CCP has attracted the most attention recently, and it has been incorporated into clinical practice now. What is anti-CCP? Anti-CCP is the antibody that is produced towards the cyclic citrulinated proteins found in the synovium, rheumatoid synovium. Citrulline is a non-standard amino acid that is produced by deamination from arginine protein. And there are different antibodies that have been described prior to definition of anti-CCP antibody, which are now known to be anti-CCB antibodies. Anti-CCP antibodies have a very high specificity for rheumatoid arthritis, like as high as 97%. Whereas rheumatoid factor specificity is around 70%. When we look at the sensitivity for both of these lab parameters, both have a sensitivity around 70%. Having both of them in high titers predicts severe erosive disease. Yes, we said that rheumatoid arthritis is a progressive disease. Looking at this data, in the early phase of the rheumatoid arthritis, here shown in white and green, inflammation and disability goes hand in hand. Later, during the disease, after the disease is established, you see that green line, which shows the inflammation, can subside. But, interestingly, disability, shown in white, correlates significantly with the radiographic changes. Joint erosions occur early in rheumatoid arthritis. Up to 93% of patients with less than 2 years of rheumatoid arthritis may have radiographic changes. These changes could be early detected with magnetic resonance imaging at up to 4 months of onset of rheumatoid arthritis. If we look at this graph, rate of progression of erosive changes is a lot more, significantly more rapid in the first year of the disease onset than later on the disease. So what does it tell us? Early diagnosis and early treatment is very important. Quick look at the therapeutic interventions. Our first goal is, when a new patient comes in, our first goal is to manage the pain. So we start non-steroidals and COX-2 analgesics if there is no contraindication. Steroids are generally used as bridging therapies between treatments, and also if we want immediate response, and we like to use them in short terms in low doses. Disease-modifying drugs, DMARDs. Methotrexate is our favorite, with long experience and relatively well tolerated compared to other agents. Leflunomide is a newer agent, has similar efficacy with methotrexate. Sulfasalazine, well tolerated, but generally kept for milder diseases. Very rarely now we are using hydroxychloroquine alone in rheumatoid arthritis treatment. Generally it is used in combination with other agents, and these other agents are kept for more severe conditions. Now, era of biologics. The most exciting ones are TNF inhibitors. I'm going to talk about this detailedly in my talk. And IL-1 inhibitors, anakinra or Kineret, also has been approved by FDA during the same time with the TNF inhibitors, but we didn't have much luck with these agents. We get modest response, but there are some patients who do well. Newer approved agents, CTLA-4 Ig, abatacept, which is T-cell stimulation blocker, is recently approved, given by infusion every 4 weeks. Rituximab, approved for rheumatoid arthritis in a matter of weeks, a couple of weeks ago. It is an anti-CD2 monoclonal antibody, which is a B-cell depletion factor, also given in infusion. Okay, changes in treatment approaches. In previous times, we had this therapeutic pyramid in which the patients were started on non-steroidal treatment for long periods. This approach was based on the assumption that rheumatoid arthritis is a benign disease. And later on, if there was very active disease, drugs like gold salts were introduced. But currently, this pyramid approach has been reversed, and aggressive early combined treatment is our goal. As rheumatoid arthritis is being recognized as a disabling disease, so what have we done with disease-modifying drugs? After 5 years of treatment, only 60% of patients remain on methotrexate, although it is the best tolerated DMARD. Joint erosions are found in 30% of patients after 1 year of therapy with traditional DMARDs and 70% of patients after 2 years of therapy. Complete remission is observed in only 2% of patients after 3 years. Over 50% of patients are disabled after 5 years of therapy with traditional DMARDs. Another point of view, published by Smolin et al., 20% of patients have no remission with DMARDs, and remission is achieved by 27%, which is defined by no swollen joint count and total tender joint count, and partial remission is only up to 50%. In this data, we see that early treatment with disease-modifying drugs reduces disability. Here, the primary endpoint was the disability assessed by Health Assessment Questionnaire. This is Health Assessment Questionnaire is performed by the patient, and it is a validated rheumatology-specific and widely accepted tool which evaluates physical function. Patients were either given DMARD treatment in the first 6 months after the diagnosis of RA, or given later on the disease. And these patients were evaluated 5 years after the diagnosis. And the patients who started disease-modifying drugs earlier than 6 months had significantly less disability. Another approach is combination therapy. Conventional treatment with a single DMARD often fails to adequately control clinical symptoms or prevent disease progression. Therefore, DMARDs are used in combination in 2s or 3s. Let's see some data. The green bar in the middle shows the combination with methotrexate, hydroxychloroquine, sulfasalazine. And the other bars are double treatments with methotrexate, hydroxychloroquine, or methotrexate, sulfasalazine. Endpoint is ACR 20-50-70, which is a response criteria generally used in clinical trials, which assesses joint count, swelling, tenderness, and other inflammatory markers. And they are defined by 20%, 50%, or 70% improvement. In this slide, you can see that triple therapy has significantly done better than the double therapy, both in all the criteria. Yes, with disease-modifying drugs, we do well with rheumatoid arthritis patients, but there's definitely an unmet need. When you look at this picture, what do you see? Is it a pretty girl or an old witch? For a rheumatoid arthritis, tumor necrosis factor is definitely an old witch. Yes, we talked about cytokines' role. TNF-alpha and IL-1 being the pivotal role, playing the biggest roles in this setting. But there's definitely an imbalance between the anti-inflammatory cytokines and pro-inflammatory cytokines. So how can we inhibit these cytokines? In normal interaction, inflammatory cytokine binds to the cytokine receptor, which results in inflammatory signal. One way to block this action could be with monoclonal antibody, this Y-shaped, or soluble receptor blocker, and ends up being no signal. Receptor blockade can be achieved with monoclonal antibody to the receptor or receptor antagonist, and there's no signal again. Final way to do is to use anti-inflammatory cytokines, which suppresses the role of inflammatory cytokines. Currently, there are 3 anti-TNF agents approved by FDA. Etanercept or Enbrel, which is a human-soluble receptor, infliximab or Remicade, chimeric monoclonal antibody, adalimumab or Humira, human monoclonal antibody. You see the half-life differences. Etanercept is not specific to TNF-alpha. It also binds TNF-beta. Dose and administration, 25 milligrams twice a week subcutaneously, or recently approved formula 50 milligrams weekly. Infliximab is started at 3 milligram per kilogram infusions in combination with methotrexate, loading dose of 0 week, 2 weeks, 6 weeks, and then every 8 weeks. If not good response achieved, the dose can be titrated up or the frequency can be increased. Humira is given as 40 milligram every other week subcutaneous injection, started at every other week, but it could be increased to every week injections. There have been many clinical trials done with these agents. So for the sake of time, I cannot bring them here. I just brought a couple of samples. This is one of the older clinical trials with etanercept in refractory rheumatoid arthritis patients. Remember that the first clinical trials were done on refractory established rheumatoid arthritis patients. And primary endpoints were ACR 20s, 50s, and 70s. The patients were randomized either to placebo and methotrexate or etanercept to methotrexate, and there's a significant difference in the percentage of patients who reach ACR criteria. A sample from an infliximab clinical trial. Here the patients are also randomized to placebo plus methotrexate, infliximab plus methotrexate, and you can see the rapid response in the yellow line here with infliximab in reaching ACR 20 response. Similar response with adalimumab, the same group of treatment, and the rapid response and persistence of active disease control. This slide shows 2 groups of patients, early and established rheumatoid arthritis with adalimumab plus methotrexate or placebo plus methotrexate. Early rheumatoid arthritis defined by less than 2 years, and there's a significant difference between the adalimumab treated group and the placebo treated group in reaching these response criteria. In addition to disease activity scores, other parameters were looked at in these clinical trials. The radiographic change, as I shown you before, correlates well with disability. So in this slide, you see that etanercept or methotrexate or etanercept plus methotrexate were given to patients, randomized patients. And change in total sharp score was assessed. Change in total sharp score shows the erosive changes plus the joint narrowing. And in patients with only on methotrexate, the sharp score has advanced. In comparison to etanercept group, this increase in radiographic progression has significantly diminished. And in the group with methotrexate and etanercept, this radiographic progression was reversed. These similar results were also achieved with infliximab and adalimumab. I didn't include it here, the other slides. Okay, after all this data, what is the current management strategy in rheumatoid arthritis? First, establish diagnosis early, very early. Initiate therapy early, and periodically assess disease activity every 2 months. If there is adequate response, great. But what is adequate response? In addition to stopping inflammation, patient's functional capacity, patient's pain evaluation, all these go into this. If there is inadequate response, change DMARDs or add a DMARD. Now we can add a biologic agent. Problem comes in with the patients who fail all these remedies. Then we have newer biologics like rituximab or abatacept. Or finally, we can include the patients in clinical trials. Okay, a new disease, seronegative spondyloarthropathies. Ankylosing spondylitis and related spondyloarthropathies are much more common than realized. And spondyloarthropathies are often misdiagnosed or diagnosed late or undertreated. Physicians need to consider spondyloarthropathy when seeing a young patient with chronic low back pain. And traditional therapies only provided symptomatic control in these patients. So we need to recognize the evolving role of anti-TNF therapy. What are these spondyloarthropathies? These are a group of related disorders with common clinical, biological, and genetic characteristics, and their overall prevalence is up to 2%. Key features are sacroiliitis, spondylitis, we know, oligoarticular or often asymmetric peripheral arthritis, association with HLA-B27, being seronegative, typical bony changes with hyperostosis, reactive bone formation, distinct extra-articular features such as enthesitis, dactylitis, and there is a male predominance. Here's a patient, female patient with ankylosing spondylitis, typical posture. Ankylosing spondylitis therapy prior to 2000 started with NSAIDs and continued with NSAIDs. And sometimes DMARD treatment was incorporated. But unfortunately, there was only modest response. Only modest, especially on the axial disease. Agents only appear to control signs and symptoms, but none of them shown to alter the progression of ankylosis. And there was an unmet therapeutic need for therapies that can preserve function and decrease disability. Of course, we looked at TNF-alpha. And sacroiliac biopsies showed evidence of TNF-alpha. And a couple of studies with TNF-alpha treatment in this patient group. With infliximab, here there's another response criteria, BASDAI, which shows the disease activity in ankylosing spondylitis patients. Significantly, patients responding to infliximab was significantly higher with infliximab-treated group and placebo-treated group. BASDAI 20% improvement, BASDAI 50% improvement. Here is another response criteria used, ASS20, which measures both disability and disease activity. And this study was done with etanercept. Again, significant response with etanercept-treated group in comparison to placebo. These patients were not necessarily on DMARD treatment, on additional DMARD treatment. Another interesting data is the MRI changes. In addition to assessing disease activity, inflammation in the spine and sacroiliac was measured by two different methods of MRI assessments. I find this slide very big and too much data there, but I'm going to shorten it to you. Here, in baseline and follow-up of the patients treated with etanercept, patient has significant decreased in the inflammation in the spine area. In the third phase, placebo-treated patients were also exposed to etanercept, and this second bar shows a decrease in the inflammation in the spine. In conjunction with this, very excitingly, spinal mobility have significantly increased, measured by chest expansion, Schober's measurement, occipital wall measurement, in the group which was treated with etanercept. And look at placebo. So, current management strategy in ankylosing spondylitis. In all these aspects of the disease, NSAIDs are used if there is no contraindication. But we need to administer other drugs as soon as possible. Apart from the peripheral arthritis, using disease-modifying drugs are not recommended because there isn't much use. So anti-TNF agents are administered as soon as possible. Injections in certain regions are helpful. Physical therapy and exercise is definitely recommended in axial involvement. A new entity, psoriatic arthritis. It is more common than previously thought. Female to male ratio is equal. Prevalence of psoriatic arthritis in patients with psoriasis, it changes according to reports because I think there is underreporting or underdiagnosis. Prevalence of psoriatic arthritis can be up to 1%. There are more Caucasians than other races. Generally, first psoriasis presents and psoriatic arthritis follows. And 1/5 of the patients have a severe debilitating disease. This is a confusing slide, but this diagnostic criteria was recently validated and published, so I wanted to share it with you. I'll simplify it. There should be an established inflammatory articular disease. It could be the joint, spine, or peripheral arthritis, like enthesial involvement, plus 3 or more of the following. Psoriasis, it could be current history or even a family history. Nail changes, typical nail changes being seronegative. Dactylitis, which is the sausage digit, it could be current or a history of dactylitis. Typical radiological evidence which shows juxta-articular new bone formation, very typical. Typical psoriatic arthritis hands. Here the nail changes, you can see clearly, I'm not going to go into details. Dactylitis here in the second and third digit probably. Ankylosis, a hallmark of psoriatic arthritis. In addition to erosive changes, bone proliferation and fusion is very common. What have we done with the DMARDs, with psoriatic arthritis? With all these agents, there have been only modest improvement in the arthritis. Skin disease have benefited some from cyclosporin, good response, but with methotrexate, we see very commonly liver function test elevation compared to rheumatoid arthritis patients. Of course, we looked at TNF. In affected patients, TNF-alpha was shown to be elevated in synovium, serum, and skin lesions. And in addition, T cells in the epidermis and dermis of psoriatic lesions have been blamed, and activated T cells release these inflammatory cytokines. Couple of samples again. With etanercept, here's another response criteria which are used in psoriatic arthritis clinical trials. It consists of swollen joint count, tender joint count, visual analog score. And in this trial, patients were randomized to placebo or etanercept and evaluated at 4 weeks, 12 and 24 weeks. In all these time points, there's a significant improvement in the etanercept-treated patients. This is a multinational trial with infliximab, very nice clinical trial design. Patients were randomized to infliximab or placebo until week 16, and then all patients received infliximab. Original blind was maintained. So in the first phase, you see the significant difference in ACR 20, 50, 70 responses. But after administering infliximab to the placebo group, they almost reached the prior infliximab-treated group. And with adalimumab, we have similar results I didn't include here. So what is the current guidelines for treating psoriatic arthritis? In all these aspects of the disease, except skin disease, pain control, and in peripheral arthritis and skin disease, we use DMARDs. We start with DMARDs. But in all other entities, anti-TNF agents could be introduced as the disease progresses. Injection has a role in peripheral arthritis and also in axial disease physical therapy. But we need to reassess the patient. These are the TNF inhibitors, again, that have been approved, and I would like to go over their usage. FDA-approved indications. All of the three agents have been approved for rheumatoid arthritis and psoriatic arthritis. Ankylosing spondylitis, etanercept, infliximab approved, adalimumab is pending clinical trials revealing very good results. Crohn's disease, unfortunately, no luck with etanercept. Infliximab has been approved long time ago. Adalimumab clinical trials are ongoing. Currently, more than 1 million patients have been treated with anti-TNF agents. These include rheumatoid arthritis and others. These three agents have similar efficacy in rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis. But there are differences in Crohn's disease as well as in psoriasis and some other aspects of safety. Switching from one TNF inhibitor to another, we do that. But sometimes we get luck and they respond. And interestingly, clinical results that we have experienced in the clinic have exceeded those from the clinical trials. And it was very interesting for us to see the inhibition of single one cytokine could be that effective. But just a reminder, clinical efficacy requires continued therapy. There's no induction or tolerance, no treatment-free remission, or there's no cure. You need to treat them continuously. Okay, in this era, we are so lucky to be rheumatologists to offer our patients these new agents, but there's definitely safety concern. Serious with TNF inhibitors, serious or opportunistic infections, most important tuberculosis, lymphomas, MS, optic neuritis, hematological abnormalities, rare, administration reactions, congestive heart failure could be a problem in very high doses. Drug-induced lupus, it is transient after the drug is discontinued. Hepatotoxicity, rare. Remember that generally most adverse events occurring with TNF blockers are manageable and will resolve upon cessation of anti-TNF therapy and administration of appropriate therapy. Just quickly, I'm going to go over this, and I think I will wrap up soon. Infection data. Data do not show significantly increased risks. However, TNF antagonist therapy should not be initiated in patients with active infection. Patients undergoing TNF antagonist therapy who develop a new infection should be monitored closely, and treatment should be discontinued if infection is serious. TB data. This is very important. Before receiving a TNF antagonist, patients should be screened for latent TB, chest X-ray and PPD skin test. Patients whose records do not indicate the size of the reaction or the PPD skin was done by an unexperienced personnel, PPD test should be repeated. If there is any evidence of latent TB infection, then anti-TB therapy should be initiated prior to starting anti-TNF agents. Lymphoma rates. This is controversial because I had a slide prior which shows that rheumatoid arthritis patients already have high rates of lymphoma. And in patients who were treated with anti-TNF agents, lymphoma rates are consistent with those expected of rheumatoid arthritis patients with moderate to severe disease. So this increased lymphoma risk, could it be from selection bias? Needs more work. Administration reactions. When you look at this slide, incidence of injection site reactions look very high, like up to 35% with etanercept. But these are transient. With the usage of local agents, they subside in a matter of weeks. Only 1% of patients withdraw in subcutaneous agents. Infusion reactions with infliximab, we see some infusion reactions, but withdrawal rate is still very low. So, contraindications. Current active serious infection, chronic recurrent infection, being immunosuppressed, congestive heart failure class 3 or 4, history of TB or positive PPD, untreated, MS, optic neuritis, SLE, connective tissue disease, and overlap patients. So, final words. Early diagnosis and early therapy is an important therapeutic goal. Collaborate with primary care colleagues. We need to utilize MRI, CT early to facilitate early diagnosis. And anti-TNF therapy has significant promise to relieve pain and improve function in patients with rheumatoid arthritis, ankylosing spondylitis, and psoriatic arthritis, and has the potential to modify the functional and structural outcomes of patients with the same group of diseases. Thank you.
The Foundation helps facilitate dialogue between Western physicians and alternative medicine practitioners in the diagnosis, treatment, and management of pain in women.